Kathleen, welcome to Suppression.
Thanks, Bob. Hi, everyone. Thank you very much, Bob. Can you hear me okay? Do I have this on right? Stephen's gone, but you can hear me okay? Okay, good. It's a pleasure to be here. I actually I think I met Susan Tross in about 1993 and Bob in one of the early centers meetings. I have this vivid memory of us sitting on some sidewalk somewhere having lunch. And so I feel like I have been a part of the centers world, really. Actually, this is honestly the first time I have not been affiliated with the P30, so I'm on my way. Okay, so let me tell you how I'd like to do today. Obviously, from the title, I'm going to talk about trauma and HIV, as Bob indicated. And thanks to Teo for giving me a catchy title. I'm never good with the catchy title, so he helped me with the pursuing viral suppression by addressing mental health. So what I'd like to do is give just a little bit of background of context of sort of how focusing on mental health broadly, much more specifically on trauma. And then basically starting with saying, here's the study I'm about to begin in South Africa. So I have a few months to maybe make some very minor changes in case you have some great ideas. You can't tell me to change the study design completely. But then talk about how I got there and sort of the progression of studies and where we've come along the phases of the epidemic. And so I figure for the old timers, it will be a way to reflect on their decades of work. And for the junior people, I hope it's an example of sort of how research progresses and one thing can lead to the next. And unfortunately, the time it can take. But so let me go till about what time? 25 till okay? Or what time should I stop, Bob? Quarter of? Okay. You guys are tricky. You know, you don't have a clock in this room, so I'll do my best to stay on time. So let me start by saying, maybe start by, I think it's on, Stephen. So I just wanted to frame some of what I just said, which was thinking about trauma and HIV. First of all, First of all, why mental health? So Bob set me up well for that, and I'll say a little bit more about that. But why trauma and sexual violence specifically as an area of mental health? And really focusing a little bit on what I'd like you to think through. The way I frame this talk in my mind is what works? What do we not know? What studies do we still need to do? And if they do work, why do they work? Like, where are we in this particular field of what are the evidence-based interventions, and specifically, how are they related to the care cascade? How are they related to getting people engaged in care, given all of our advances in biomedical approaches, and this question of getting to viral suppression? So the way that I'm framing this is, if and when the goal is viral suppression, which we could certainly have discussions about, but I will say at my last site visit at the CFAR at Duke, when I said, are you still, to the site visitors from NIH, are you still interested in mental health studies? They said, of course, as long as the outcome is viral suppression. So, and I just think that's where we are, which is why I do want to sort of think about where we are in this field. So because it is World AIDS Day week, and I once made this slide of 30 years of myself, not really myself, but just thinking about what has happened over the decades, in the context of my 30 years. I do think of it in 3 decades, basically. The first decade of no treatment, many people died. My work was all about grief and bereavement, and everything we did in those 10 to 20 early years of no treatment. And honestly, where we really weren't permitted or funded to do any kind of prevention with HIV-positive people, which maybe sounds sort of unbelievable to you more junior people. But because of the stigma and the lack of treatment, we were very focused on primary prevention as opposed to prevention with positive. Then in '96, when we had this sort of in my own middle decade, kind of the middle of where we were when we first had treatment, was my own sense of where then mental health came into play much more. Then we had some hope for treatment. We started thinking about secondary prevention, prevention with positives, and integrating mental health trials into that. And then I think, certainly in the last 5 to 10 years where we got such advancement in biomedical treatment, now we're very focused on, even though mental health matters, we still need to look at the biomedical outcomes. So I just wanted to say, reflecting on World AIDS Day and the amazing progress that we've made in 35 35 years basically in the epidemic, and how much hope we should have for the future, given how far that we have come. So let me just say in my own bit of, and to say that the focus for World AIDS Day is that communities make the difference, which I think is obvious to all of us, but great for the recognition of the focus for this year. So let me just say that even though it's the 31st year of World AIDS Day, I have my own 30th anniversary for World AIDS Day. So this is World AIDS Day, oh gosh, this one should be first, 1989. So for those of you that are too young to even know that you used to be able to drive in front of the White House, that when you would have acts of civil disobedience, and these are during my doctoral student days as a volunteer and community activist. This is me getting arrested with ACT UP, Fight Back, Healthcare is a Right in 1989. Which we still say today, and we're still fighting for today, and we still have to keep fighting for today. So in relation to mental health, what I would say is, as we say in global mental health, there's no health without mental health. And so that's what we're seeking constantly, for parity of mental health and health. So just to frame the thinking about mental health, as Bob said, we know mental health is associated with risk behavior, primary prevention, HIV treatment, and treatment as prevention. If we put mental health in the middle of those circles, it's related to all of those goals. So we know there's associations. We know we have evidence-based interventions that actually can work, that can be adapted for these different contexts and goals. But I think there's still room for innovation, and that's one of my sort of guiding questions of what studies do we need? What works? What haven't we addressed? How might we approach these kinds of interventions? Thanks to Bob, I borrowed this slide for what he just said. That looks familiar, yeah? About the high burden of mental health and HIV, and importantly, all the various intersecting influences that range from structural influences, as noted, to individual psychosocial, to stigma, trauma, violence, as well as biological. So thinking about this from the global mental health perspective, where we know that in low resource settings, which doesn't necessarily mean outside of the United States, up to 90% of people with mental illness do not receive treatment, and we know in many settings there's no providers, and so that's one of our big challenges. About 5 years ago, I did a review. My team did a review of what mental health intervention trials there were out there in low and middle income countries, and we were able only to identify 22 separate studies. Again, this was 5 years ago. I think there are more that have come since, but quite surprising that only we were able to identify 4 effective RCTs that were full trials, but in a very good way, we identified, I think it was 11 pilot studies, which I thought were an indication of the future of doing mental health intervention trials. So to bring us to the focus for today, what we looked for, Aisha, my project coordinator, did a search of what's out there on NIH Reporter. So if we acknowledge that we don't have that many mental health intervention RCTs, especially in low-income countries, but with this push with viral load as the outcome, I know we have many with adherence as the outcome, but very few with viral load suppression as the outcome. We were able to identify 6 that are RCTs. One is a pilot that are focused on mental health with, as I said, viral load as the outcome. Most of them are focused on depression. Not all. Some are on discrimination. But mostly depression, and in South Africa, Zambia, I think the Wagner one is in Kenya. So many of these are in global settings. And then there's this category of 3 that are more sort of social network systems based, which is sort of how do you set up a system model and a service model. And for example, the asterisk ones actually are where in the abstract, at least, they say that this is the primary outcome, but we're also going to look at the mediating factors, which is one of the points that I think is really important, which is if it works, why does it work? Because we can't necessarily move it. I don't believe we can move them well to implementation without knowing what it is about them that really might be the most effective mechanism, especially if they're multi-component kinds of interventions. So how do we set up study designs and think about the trials that we do so that if they do work, we can understand how they work. At least in the currently funded grants, other than the one of mine that I'm going to talk about, there is one by SAILS that's going on related to implementing trauma-informed care, so it's much more of a systems look at that. So my point about trauma and HIV, and so here are a few, and it's interesting, these references come over time, but basically we know that trauma is associated with HIV clinical outcomes, but we've very not frequently addressed it. So we know traumatic stress is comorbid with other mental health disorders, and it's linked to poor care engagement. We have example references here, but they're not the only ones. We know that sexual trauma adds to the stress of managing HIV. And I should note that the prevalence studies that try to assess how the extent of sexual abuse and sexual trauma among HIV really range, I think, based on how they do the prevalence and the assessment, anywhere from, I would say, 25% to 75%. But I always contextualize that to say, because someone was, how do I say this? Just because they have HIV doesn't mean they were sexually abused. They were able to distinguish this in the WISE study looking at women, which is it's the behavior it's what the status of your partner is what I'm trying to say. That trauma leads to certain behaviors. Whether or not you're infected is based on the person you're having sex with or injecting drugs with. So you just have to be careful about adding to the stigma of HIV and sexual abuse to think about the potential causality of the high prevalence of sexual abuse among HIV-infected people. But when you look among HIV-infected people, which is the studies I have done, you do see very high prevalence. We know trauma contributes to avoidance. I'll talk about this more. That's sort of a big part of my rationale for what intervention content should be, and that it can result in compromised immune compromised immune function and increased infectivity. So there are a number of studies that talk about the association with clinical outcomes, and a couple, although they're a little bit older, that suggest that women with sexual trauma histories progress faster to AIDS and face greater AIDS-related mortality. I mean, I think those are two good examples of probably related to adherence and other care engagement. It could potentially have a biological influence, but probably behavioral. This is another interesting, this is a summary of Correlates of Adherence by Abigail Hatcher, which takes a number of studies and sort of stacks up the effect size, because we often think about what's related to adherence. We think of depression and substance use and practical factors and you know, the consistency of pill taking, but actually in her review, the strongest effect, even though it's at 0.4, there are obviously other factors going on, was intimate partner violence. So, and actually a study just came out from the Pedophore group on the prevention side of things with young women in South Africa, that actually depression and violent partner in response to requesting condom use were predictive of HIV infection. So, and it's in a longitudinal study. And so I think there are different pieces that talk about the importance of violence in prevention or in treatment. So my assumption in this is that, and what we've been able to find, is there are not evidence-based interventions that are trauma-focused, that reduce traumatic stress, increase care engagement in a way that results in viral load suppression. So this is sort of the premise that I'm operating on. So here's the study that we're about to start, and I'll just tell you what it is, so it doesn't have to have like, gosh, what's it going to be, because I think it's important to think about how we got here. So the idea is this experimental intervention Impact Plus, which I'll talk to you more about, is intended to reduce avoidant coping and traumatic stress, which was expected to result in improved adherence and retention and care so that there's viral suppression. So the study is totally powered on viral suppression, which is a challenge for those of us doing single R01s, very, very challenging, and without being able to go over the cap. So we'll see what we can do. But the point here is that the intervention content is related to what we expect the mediating mechanisms to be. And this is the study design that we landed on. And let me just tell you about it generally, and then I think how we got here will be more clear after I tell you about the pilot work. And the studies that led to this. So the idea is, that it is sort of, the premise is on addressing avoidant coping, because we know avoidant response is a result of trauma. So the idea is, part of the innovation is, Many adherence studies look for defaulters. Basically, this study is about preventing non-adherence. So, and this is the way I like to think about my studies, which is how can they reach the most people? And so if we make assumptions that there are high levels of trauma, this is about sexual trauma, but we'll talk about all the other traumas that people also experience, that if we screen for trauma at the outset of coming into HIV care, so basically at diagnosis, which now means getting put on ART, which is great instead of waiting, can we address trauma in a way that starts, it's sort of like a window of opportunity. We call it start strong, stay strong. Like how do you like address this trauma, acknowledge it, and the behavioral response in coping and emotionally, as well as adherence, so that when you start your meds, you stay on them. I mean, it's sort of simple, but it's not usually the way studies are designed, and honestly makes it harder to show an effect. So, but it is this idea of prevention of non-adherence as opposed to defaulters. So the way that people will enter, I'll tell you more how we did the pilot, but basically within the first few months of being on ART, they would be screened for trauma and potentially entered into the trial. They'd be randomized to this experimental intervention, Impact Plus, which is 6 individual sessions, we'll come to talk about that, as well as booster sessions over time. Will be compared to what we hope is, I should say this is in Cape Town, South Africa. It will be compared to what we hope by the time the study is over is standard of care. So this is a very sort of ethically informed, what should the control condition be? I mean, you can't go in and screen for trauma and give them nothing. I don't even think you can go in and screen for trauma and give them nutrition. Like we talked a lot about a non-mental health control condition, which is very good from a scientific perspective to be able to determine causality, but we felt wasn't ethically appropriate. So there's a large implementation trial going on right now in Cape Town for depression and alcohol use with problem-solving therapy. Our colleagues are very involved in setting policy on mental health in South Africa, and so I certainly didn't want to finish this study and have had not a good control group. So when you think about how long it takes to finish studies, where's it going to be in 8 years? And would we be terribly criticized for giving a wait list, or honestly treatment as usual? Because treatment as usual is a referral letter hoping you might get evaluated by a physician, which also is not ethical from our perspective. So we've also set ourselves up to compare to another intervention that's similar, but is shorter because it's only 3 sessions. All right, so we'll come back to the complexities of why we picked what we did and what the strengths and weaknesses of that are, with assessments over every 4 months. So that's the big picture of where we're going after 20 years of trauma research. So Bob told me not to scare off the junior people. That I did a few studies in between the first one. All right, so let me just say the theoretical framework for the interventions that I use is based on the cognitive theory of stress and coping, which was Lazarus and Folkman in 1984, adapted by Susan Folkman into this decision-making cognitive stress-reducing tree as applied to HIV in 1991. So how did I first get focused on this? As I said, my first mental health trial was an AIDS-related bereavement in like 1994, 95, when that got funded, I think. And the extreme complexity of having the same disease as the loved one that you lost, maybe that you infected, maybe that infected you, the loss of your child, what really was traumatic grief. And so I used this intervention model and by consulting with Susan Folkman actually, because it seemed like this changeable, unchangeable stressor could be well applied to HIV and bereavement, because the greatest stressor were things that were not changeable. And so there may be some sort of problem-focused coping strategies for those, but it was 1995 and that was the world we were in at the time. So what was interesting about that is as I realized, I ran all those intervention groups actually. So in our early days, we ran all of our own interventions. I think I keep looking at Bob and Claude, but that's probably true for Susan, for many of us that by delivering all those interventions, I realized that there were so many other traumas experienced. And I thought to myself, because I got a PhD to be a clinician, and so I thought to myself, why Yes, almost all the people I saw in the late 80s had sexual abuse, right? Like all the gay men I've worked with in Western Virginia, I went to Virginia Tech, and so it was a fascinatingly terrible, stigmatized place to have HIV. But many of those people had sexual abuse histories. And so I'm like, usually the clinical work informed my research better than it had, but it sort of took the work in bereavement and grief to really get focused on trauma, and then all of the sexual trauma that I then heard people talk about. So this is just a way of thinking about avoidant coping, that we know this from trauma and PTSD, that at least my sense of people that cope with sexual trauma more effectively tend to deal with it sooner. I mean, that's the more you avoid, the less adaptive you are, which can mean disclosing about the trauma, seeking support about the trauma, and so on. But the coping model led me to this focus on avoidant coping, which we know is related to poor health outcomes. And this is not just HIV specific. Generally health outcomes, care engagement, risk behavior, and distress. So this led to LIFT, the first study I did on sexual trauma and HIV. And the idea behind that, this was written in 1999. So this grant was written in 1999. So just sort of think about sort of where we were then. The idea I had was, could you do a mental health intervention? My first decade was all about HIV prevention, community level trials, very focused on condom negotiation and behavioral skills. So the question then was, could we do a mental health intervention focusing on sexual trauma that we know is related to risk behavior? I mean, the CDC and NIH did this. I'm very grateful for this amazing meeting in 1998, where we went to CDC. They brought together the sexual trauma experts with HIV experts in the room, like 20 people together. And the sexual trauma people are like, you HIV people are like 2 decades behind. We have known from sexual trauma all this time that, of course, this is going to lead to HIV risk behavior, sexual behaviors, and substance use. We know that about sexual trauma. So fortunately, then I could work with those sexual trauma people to develop this intervention idea that if we actually address the trauma and the mental health, might the effect be an impact on behavior without pulling out penis models, without doing condom role plays, all the things that we were doing for behavioral skills then. And so that was the idea, and here's what we found. So the study design, I should say, was very U.S. Western, 15 sessions of group coping intervention compared to 15 sessions of basically interpersonal support therapy. So very similar to my current thinking, which is compare 2 treatments, because if you don't compare it to anything, it's good for efficacy, but then do we really know if that was what worked or not? And they had the same number of sessions, all group, similarly trained therapists, so that and this was done at Callan Lord, and these studies were all actually done at Callan Lord in New York, giving my bouncing from Wisconsin to Yale to Duke and to here, so on. So anyway, so it was really, I think, a strong study design, and actually I think why it's the only CDC evidence-based intervention on trauma right now, because it was time matched with the follow-up period. So these were our outcomes on sexual behavior, and I'm going to do this briefly. Look at the trajectory. These were general linear models, looking at the trajectory of change over time. But basically that unprotected, and there were men and women in this study, gay and bisexual men. We tried to get heterosexual men, but we couldn't get enough at a time to randomize. As I often say, Matt Lauer was talking about the abuse of the Catholic Church in those days, and I thought if anybody's going to get heterosexual men to come out, it would be now. Who would know what would happen to Matt Lauer in the Catholic Church? But that's a whole nother, but anyway, we couldn't get enough heterosexual men because of randomization. We would need like 20 or 30 men to come in. Basically, by saying I want to be in this study, you're saying I have HIV and I've been sexually abused. And so it was men, but men who had sex with men. So there was reductions in unprotected vaginal and anal intercourse with all partners, meaning positive and negative partners, reductions in alcohol use, reductions in cocaine use, and then this is a complicated mediation model. But basically, there were significant reductions comparing the 2 treatments to reductions in traumatic stress, this part, reductions in avoidant coping, and those changes over time in traumatic stress were fully mediated by the reductions in avoidant coping. So it was our way of being able to say, okay, at least the psychological conceptual causal model makes sense. We had not been able to make that mediation to the behavior. All right, that's if we, and this is just a statistical comment, we had great difficulty making that model run, and so I don't know the answer to that in this data. Had to do with different statistical things. Maybe now, 15 years later, we could figure out how to do it, but it's the logic behind the current grant that I'm doing now. So are you with me on sort of the history of how I got interested in this topic? Based on the sexual behavior outcomes, it was best evidence for CDC, and based on the substance use and mental health outcomes, it was SAMHSA approved, as I say. Interestingly, just less than 5 years ago, I was at a meeting at NIMH about trauma and HIV. And there have been some since this time. I'm just trying to give you a bit of the progression. But there were only 3 studies that had been identified in a systematic review by Conor LeClaire and his group, because he's also, their group now is doing a lot of work on trauma. And he is an expert in that area. And then NIH looked further, and these were the 3 that were identified. So there's LIFT that I was just talking about, but it's quite surprising, I think, that just 4 years ago, this was all that NIMH could come up with in terms of where we were with HIV adults. Claude and I were talking about there's been some other trauma-informed for children, but not necessarily with these kinds of behavioral outcomes, or certainly not biological outcomes. So what struck me then about the trauma, the LIFT findings, was this whole question of, well, are there other mental health studies out there that could show an effect on sexual behavior or substance use? And I worked with Seth Kalishman for years, and I sat down with him and I said, do you know of any? He's like, no, I don't know of any. And so we basically put together this model to say, why aren't we doing this? So 10 years ago, this conceptual model, and what I actually think is that people probably collected that data, but they might not have looked at those results. I mean, often in a mental health study, you might have asked substance use and sexual behavior, but maybe didn't focus on those for some reason. But so this was the model we created based on those findings about 10 years ago, which is thinking of mental health intervention, whether it's pharmacologic or behavioral, in what way that might influence mental health symptoms, substance use, stress and coping as the mediators that could potentially reduce sexual risk behavior or substance behavior, improve adherence, and Steve Safran at this time was starting to do work related to depression and adherence. Could that reduce viral load? And this was really a prevention model, to tell you the truth, to stop the transmission to others, right, focusing on HIV positive people. And now that we're all about viral load, it applies, basically. Okay. So this is sort of my sort of U.S. focused work in trauma that led to my interest in doing trauma-related work in South Africa. So I was thinking about this morning. My first project in South Africa, I think, was 2001, which was a pilot study funded by the World AIDS Foundation, because I don't think NIH was quite to this place yet, honestly, like focusing on this kind of work. To see if it was a good idea to integrate HIV prevention into services for abused women. So I worked with this NGO called POWA, People Opposing Women Abuse, and this, like, is it a great time because women are coming because of domestic violence or rape and where they might be getting legal services or shelter, or is it a terrible time? You know, is this just something that shouldn't be addressed when one's trying to figure out what to do about their sexual trauma and violence? And we actually found that it was quite acceptable and worked best with women who were coming to shelter, right? Because they're in the shelter. And so it was interesting to me, like, well, this could be I didn't ever pursue this idea, but this idea of women getting out of abusive relationships, at least as a first step, and would this be a place to integrate HIV prevention and mental health? And so, and interestingly, it was a small study and we couldn't show a lot of effect on behavior, plus the women had come to the shelter to get out of the relationship, but it was a small RCT. But we actually found a suggestion of an effect that it impacted getting out of the relationship. So, and staying out of the relationship. So, I mean, I think sometimes when we intersect these worlds of syndemics, that's why I'm using this example right now, you know, we know that HIV, like substance use, violence, and HIV, and this Merle Singer coined this term syndemic, where we have arrows that are affecting each other related to HIV, mental health, violence, substance use. This, I think, is a complicated question. Like, should one target? Well, I'm going to say I'm going to do a study on this particular part, but try to take these influences into account. Should we be doing poverty alleviation? Claude and I were saying, like, should we be doing big level structural? Sure. But can we also be doing individual and clinic level? Yes. Like, I don't think that one should exclude the other. So thinking syndemic and knowing that, I just had wanted to make the point about prevention, more about prevention before I go into the HIV treatment in primary care. So the model that I mentioned, Seth Kalishman and I had done this multi-method longitudinal cohort cross-sectional ethnographic study together in Shabines outside of Cape Town for HIV risk, alcohol, and gender. And we had really a lot of fascinating, I may have said this before, like it's the only RR1 I ever had that wasn't an RCT. And it's really amazing the things you can learn and do when you have qualitative and cross-sectional and longitudinal cohort studies. But so that's my only experience. This is one example. So using that one example from the data we collected in that study. So it's basically the same model where we're thinking about trauma and gender violence, how it relates to, to mental health. And in this case, it was alcohol use, sexual behavior, and HIV. I just want to point this out as an example of, it's kind of referring back to depression, rightly so, is probably the most prevalent mental disorder among HIV and has received the most attention. But this example looks, this was in the Shabine study, a cohort of 560 women that we followed over a year with like 95% retention, with 4 time points, with measuring a lot of different variables. But what this graph shows is how depression and PTSD and alcohol basically intersect. So we know that in this study that there was an association between, depression and alcohol use. I mean, that doesn't surprise us, right, over time. But what this shows is an interaction with PTSD. So basically, if you look closely at the level of depression, when it's a low level of depression, look at it by PTSD. This is an easier way to explain it. When PTSD is low, there isn't really a variation by depression. As it increases, it becomes much more significant. So it's basically looking at how PTSD interacts with those. So I use this to say, yes, we should address depression, but we can't let PTSD be masked by depression because we probably need to address it differently. So I just use this as an example. So back to this idea of how do we, and my work over time in South Africa is focused on women. My work in the States was, as I mentioned, broad women and men. So this idea of all the various influences on women's HIV risk and disease progression that I've decided to taking this area of focus on trauma. When we think about the continuum of care and the cascade, I think we could do interventions at any of these points. We could think about trauma as it affects people getting tested, right? We could figure out how does trauma how does it interfere with getting linked to care? What I'm focusing on is once you are to care and you're most likely newly diagnosed, that's our target audience. Once you get on ART, this is really the focus of the study that I'm about to do. So let me tell you how we got to where we are. We got an R34 pilot intervention. For those of you that are thinking about how do you develop your grant ideas, R34s are basically intervention development and pilot trial grants, not provided by every NIH agency, but by NIMH for sure. So we basically wanted to, and I did this work with John Jaska, who Bob has also worked with. We thought in these co-occurring epidemics of HIV and sexual violence among women in South Africa, and this, what I noted before, that trauma leads to greater HIV risk and potentially poorer health outcomes. How might we address trauma to improve care? So just giving you a little more background about what I noted before. Not ignoring the syndemics, not ignoring the context of social and economic influences, where our people. This is the setting of where people live. This is across the street from the primary care clinic where we work. Like we're not ignoring the poverty and the structural, even though we're doing an individual intervention, trying to figure out how you can at least acknowledge those and take those into account. So just on a little bit lighter note, given have you ever seen this, Bob? So given that we're acknowledging World AIDS Day and the value of communities, we must also acknowledge how challenging it sometimes can be to do community-based work. So I love using this picture because after 2 or 3 years of the city of Cape Town telling Joska, well, we think we're going to add on to the clinic, there's going to be more room, and so on and so on. So just after, and this is the part I don't know if you know, Bob, see this Cape Town worker in the red outfit sitting on these boards? This was originally Bob's office. This was originally one of your prefabs that your study was finished and we had just repainted and got new furniture for when the city of Cape Town said, we're going to knock all that down, we're going to build a new clinic right here. And so here sits our office space. With the city worker sitting on top of it. So it's a light way of saying you just can't always predict what's going to happen when you work in a community-based setting. And honestly, we rebuilt it in the back of the clinic, and it was robbed repeatedly. It was people went over the fence. I mean, so we worked out a way to work within the clinic, which was actually safer for everybody. But there wasn't really a space for us to do our work. So there are all those practical things as well as like getting really engaged with the community. So let me tell you about what we found in the pilot work, and then we can talk more about just these trials in general and sort of the approach for my study that I'm about to start. So we first, of course, did qualitative work. So the progression, at least of this R34, as many of them are sometimes set up to be, are gathering formative work through qualitative interviews, focus group, tailoring measures and interventions. I'll tell you how I use LIFT and how I didn't use LIFT in a moment. And then testing it in a pilot trial. So this was a small sample of women, and these were women who actually were not newly HIV diagnosed because we wanted women to be able to reflect back on their adherence and their experience. And we found some very similar themes as I had found in the US work, which is not surprisingly that there are multiple and complex trauma experiences. Very few people ever have just one incidence of sexual trauma, often with different perpetrators. They would describe the challenges to interpersonal relationships, and they wouldn't necessarily, the participants wouldn't call it avoidant behaviors, but basically it's what they described. This was the most distinct one, and I must say either I didn't ask the question this way or it's much more of a South African context. Half of the women felt that their HIV infection was directly attributable to the sexual trauma. And that could be an ongoing abusive relationship with a partner that they knew was HIV infected. It could be a stranger rape. I mean, but it was interesting that was so directly said. And another quarter talked about it being indirectly linked, like having a set of insight of like, after this happened, I started using TIC, which is meth, or I started, doing substances or this or that, and then I had much more risky sexual behavior. The reason, I think that's very interesting psychologically. I think the reason it's relevant for adherence is then they went on to say that those sexual trauma symptoms make my HIV adherence more difficult because when I take that pill, I'm reminded of that rape. And so it's a really important thing to think about. If that's the attribution for my HIV infection, I'm reminded of that sexually abusive or assaultive experience when I'm daily taking my meds. And so I think it argues for this tailoring of addressing trauma in the context of adherence, because we don't necessarily know what someone is feeling or thinking in that situation. The other thing I would say is if the healthcare providers felt totally not prepared or unable to address sexual trauma, but in fact, we didn't meet any woman who had ever told a healthcare provider. So, it's certainly a two-way street. No one wants to tell, and the providers wouldn't know what to say anyway. So that's some background. We also, the other interesting thing we realized as we were getting started, we knew we'd have to figure out how to screen. But we also, unlike the US-based study where we're like, here's a study, do you want to come to it? We wanted to also do it systematically within primary care. We didn't want to have a biased sample. We wanted to set things up that would potentially be possible to implement in the future. So we went through this 2-month period where every woman who was told that she was about to go on ART, which over half meant that they were newly diagnosed, would be told there's a study that people are screening for without knowing what it was, so we could get a better sense of what the level of concern was. So in this test of could we actually screen, would women tell us, would they come to be screened, we actually found it was 70 people over a 2-month period, 70 women. Half of them reported to us sexual trauma, which is really interesting because they had never told, most people would say they hadn't told anyone. It's my belief if you ask, people will tell, but people don't bring it up. right? And so I think if you're asked in an appropriate way, then somebody will tell, but they're very frequently not just going to bring it up. In a brief screener for depression, 40% suggested depression, closer to 60% suggested PTSD, and 3/4 had physical intimate partner violence in addition to the sexual trauma. So here's how we put the intervention together. We basically said, what are the core elements of LIFT? I should say that LIFT, the trauma study in the States, was mostly based on the coping model, but we also looked at other evidence-based treatments for trauma. Like, for example, we heavily incorporated cognitive processing therapy. So we wanted to draw on what we knew from LIFT. How do we tailor that to the South African context? And I'm trying to figure out, yeah, so this is where we've, and I'll be honest, the idea to focus on new initiators, people just starting ART, was a study section recommendation, just if we want to talk about the grant review process, that I wrote the first, or maybe I can come back to this in questions, but basically we really revised the first grant application. I'm not too embarrassed to say this, it didn't get scored, my first application, because it was too broad, which is what I thought an R34 should be about. I wasn't sure if it should only be sexual trauma, should it be physical also? And so the whole proposal was, let's figure out what we should do. And the reviewers wanted to be much more specific, even though it was a pilot trial and an intervention development grant. So anyway, we were very responsive to the reviews, and one suggestion was to get more targeted and maybe new initiators. So in fact, that was a great suggestion because it does make it different from other studies. So that's how we got focused on whether this was a critical point in time in their engagement and care, basically the very beginning of it, and that it made sense with trying to deal with avoidant responses. So this was a lot of fun for me. This took a lot of time, but I'm going to give you a few examples of how we took evidence-based concepts and culturally tailored them to the South African context. So, this is probably the clearest one. This is basically cognitive behavioral therapy. The head is what are your cognitions, the heart is how do you feel, and the hands are how do you relate to others. And so the first thing, I will say, even our UCT colleagues, when they saw the Folkman decision tree, typical US cognitive coping, they were like, what are you talking about? So if our PhD peers are like, this is ridiculous, what would the participants think? And it was this realization for me to think about how can this intervention be more emotional and tactile and really be not just tailored in words, but really tailored in expression and sort of the way that people live. So the one visual I don't have here is we also use a little bit of motivational interviewing since we're getting people to like get motivated at the beginning of adherence. So we use literally like a bridge from a game or from a toy set, because we use the bridge to identify what do you value, what do you need to get across the bridge to be committed to taking ARVs. And the values are things like family and my children. And so we use lots of things that are interactive in that way that are really based on evidence-based concepts. So this one, this is the Mbisa pot. So in cognitive processing therapy, some of the key components are power, trust, self-esteem, and safety. Intimacy, but I'll explain why we say trust instead of intimacy. So in a classic US model, we had an acronym. How many of you have done an intervention and used an acronym? SIPS was the acronym for that: safety, intimacy, power, and self-esteem. It was a way to sort of talk about those concepts that trauma affects and that what we're going to focus on in this intervention to rebuild those components. So the first funny thing was, well, when you translate those into Xhosa, all those words start with vowels. So an acronym isn't possible anyway, which was this practical, interesting thing. And then we came to this idea of what represents this culturally. And so this pot is what a lot of women cook in, a lot of community cooking, much more collectivism than individualism, that has 3 legs. And when you have a 3-legged pot, if you don't have one, it can't stand up. And so the idea is to represent power, trust, and self-esteem as the foundation of the pot and the communal pot with safety as the lid. So it's just another way of taking the concepts, but being able to use it and not use so many words and use interactions. And then this is how we use the coping model, the Folkman coping model, which is, it's hard to see here, but literally, We take a bag of pebbles that are painted purple and orange, I guess for South African tailoring, and those are the global stressors, the heavy weight of your big stressor. And in order to specify those stressors, you start pulling the rocks out, and orange is changeable, orange is unchangeable, purple is changeable, just so people can begin to develop this skill set about coping. So this was actually, took a lot of time, but was a lot of fun, and we've gotten a lot of good feedback on it. So we developed this into 4 individual sessions. As much as I wanted to do group, I knew that if women weren't telling people, and that maybe starting individual was the way to go, and then move them into group for the benefit of the social support that comes from that. So this was the study design. As I was saying, they would be screened as they enroll in ART at the clinic. And then at this point, we had the 4 individual plus 3 group. At this time, we decided to compare it to, in the clinics, and the policy there in South Africa is that you're supposed to have 3 sessions of adherence counseling before you get the medication. So these are these 3 standard of care sessions. And so it was actually, for a pilot, it seemed a reasonable comparison. We're, of course, referring if they need mental health treatment, and we can offer them to them after. This made the design a little complex, which I'll talk about in a minute, because basically we needed to baseline them before they had their adherence counseling, before they had the ART. So you could basically come in, potentially be screened. Do you want to be if you meet criteria for the study, we'll baseline you tomorrow so you can get your adherence counseling the next day. So it was this tug then about what would be an adequate control. And so there were some things that came out of that, and we haven't done it that way. We're not doing it that way in the full trial. And then there were 2 assessments at 3 and 6 months. Just a little bit about the data at baseline, and this is like a sample of, we proposed 60 people. That's pretty common in a pilot trial this size. So among the women who had some type of sexual abusive traumatic experience, this is the distribution of the kinds of experiences they had. So not surprising. I think that the childhood is probably higher, but people may not have acknowledged the childhood abuse, but certainly we're acknowledging adolescent and adult. I think what's really important from what we're focusing on is that almost 40% had had a sexually abusive experience in the last 3 months. And then if you look at intimate partner violence, 85% had ever had that experience, and a quarter had had that in the last 3 months. So I think it supports this. There's a lot of things going on, obviously, as someone starting ART. And there's all kinds of other traumatic events that we assess, which almost everyone experienced. A question, Claudia? Sure. Yeah.
So all you did in the beginning was argue it.
Correct.
That's incredible.
Well, and here's one other step in that consort diagram is that 60% of the people met criteria for any sexual experience, and then among that 60%, this is their prevalence. So it's not this this is of the people.
85% of everybody.
Like that screening period. Over the time we recruited for the trial, 60% had reported to us some kind of sexual trauma experience. Among those who at least had one, then had this distribution. Yeah.
You know, on the last slide,
Yeah.
the percentage that had an experience in childhood, adolescence, and adulthood, so all children.
Oh, it's a good question. I can figure that out. It's not presented that way. In the U.S. study, it was like 90%. Actually, in the U.S. study, it was childhood sexual abuse, and they all had re-victimization as adolescent or adult. So that's why I actually think the childhood is probably higher, but not reported. But it's a very good question. So just an indicator of level of distress among these women who'd had sexual trauma of some form, and then we see that it's relatively high. Over half of the people, so we gave anxiety measures, PTSD measures, depression, lots of other measures. I didn't present all those. But from 50 to 65% at baseline on those surveys of self-report had a level that would be suggestive of something diagnostic. So again, this is my approach to research in this nature, which is, I actually believe that, and I was advised by this from the trauma experts in the LIFT study, which is because the occurrence of trauma symptoms can go up and down. Like setting a criteria to say you're in the study or not is a very challenging thing to decide on what to do. And I have in my work, but I certainly respect and see the great value of doing the disordered approach. So I'm often careful to say, this is not necessarily a PTSD treatment. You can have had trauma experiences and have symptoms that have affected your coping and adherence behaviors without a full PTSD diagnosis. So that's just my philosophy about how to do this to reach the most people possible. So these are the outcomes from the pilot. I know they're a little hard to see, but let me just tell you. At 3 months, we saw a trend in total PTSD scores and significance at 0.05 when we look at the subscales, and not surprisingly of avoidance and hyperarousal. But basically, those effects are lost by 6 months. In the motivation to adhere, we see something at 3 months with trends by 6 months. There was still a trend in hyperarousal. We did a form of clinical significance and actually found 47% of the impact participant had something suggestive of clinical improvement. So the reason you look at data in this way is because you're writing an R01, right? The whole point of these kinds of studies is not to show efficacy, even though they expect you to be able to say there's a reason we think this has potential, and so we want a full trial. But you do often get pushed to over-interpret your pilot data, so I want to just make some comments on that. This was then, this is interesting, that this is the percent in either condition. Blue is the standard of care and green is impact, of women at 3 and 6 months who basically reported some form of non-adherence, whether they had missed a pill on self-report or missed appointments in the clinic. So I know we talk about we have biomedical solutions and people are on them, but this subset within 3 months, a third of them are already non-adhering in some way. But then I'll show you some contradictory data, which is why I'm being cautious about the interpretation of the pilot. So I was explaining that in the beginning, so the nature of the study design meant people came into the study that they're not on ART yet. They start after they get the counseling sessions. So we realized, and this is what you do when you have a small sample, that there were a few people that actually were defaulters who had very different patterns, and there were people who never started. They decided they didn't want to start. So we permitted ourselves in this pilot version to say, all right, let's look at the people, which is 85% of the sample, who actually did initiate. And when we look among that sample, we do see a change in coping, all right? The other findings were in the published paper. These honestly were, I was told the pilots needed to be published before I could get an R01 reviewed positively, so we did everything we could to get the pilot published. And then in the critiques, we went back and gathered a lot more data and thought about these things differently, which is often the process in revising for an R01. Happy to talk about that. So basically, we were able to show that active coping improved more over time in the impact group. And then we had... in the process, I think Bob started doing a DBS study, dried blood spot study, that we weren't funded to get dried blood spots to measure the meds in the blood, but we thought we better see if we can do it. We need to show that we can do it. So we'll go ahead and find the money and add gathering dried blood spots to measure adherence. So I'm thinking, that's impressive. We did it, right? But we didn't report any results. So we went back and said, all right, if we look at this subset of 85% who were actually new initiators, and we go back and look differently at our biomarkers. We were using like any viral load that approximated the time frame. But we went back. South Africa has this great national database where we could actually go in and find viral loads much closer to our actual 6-month date. So we got more viral loads, and we looked. So we basically said if you had a dried blood spot of indicating your adherence, and or we had a viral load that was within a 2-month window of the end of our study. So it actually mapped onto our study design, not what the med record said. We actually see remarkably a significant difference in suggestions of adherence. So I give this as an example to those of you who are maybe writing your first R01 or revising one, and sort of it feels so defeating to get not funded or the things they say to you. But my experience has been that it has greatly improved what my studies have ended up being by being responsive to review. A little bit, I know I need to wrap up, I'm almost done. A little bit about the intervention itself. We technically had high fidelity to the protocol, like we covered everything, but we didn't cover everything as expected per session, right? That's like what you want to do in a pilot. We had way too much in the first 2 sessions, but we got things covered. We had very good attendance, I think, at individual, average of 3 sessions, 2/3 attended all 4 of them, only 12% 1 session or less, but basically no one came to group. Like 25% of the people came to any group. Okay, and I do want to note that 25% of our participants, we needed to do some kind of evaluation about whether they needed further mental health services. They didn't necessarily all get referred to the psych hospital or to the physician, but enough that the project director had to talk it over whether they needed some kind of assessment. So obviously we're dealing with with lots of challenges in mental health. We had a run of high suicide risk that we had to get to hospital, women to the domestic violence shelter. So all of these things this is part of why I think people don't work in this area, which is, it's complicated to do this research and there are lots of other intervening factors. So I don't want to go back to the outcome slide, but I think this is a potential explanation for why the effects were lost at 6 months, right? I mean, basically, our study design looked at the effect of the individual sessions and then a maintenance period, because even though they were supposed to be getting an intervention in that last half between 3 and 6 months, they weren't, because people weren't coming, and I can come back to why I think the group didn't work. So for that reason, we've ended up we've extended it from 4 to 6 individual sessions, and I'm happy to talk more about the content, but you had a sense of it from the way I talked about the key elements that we adapted. We've decided that there should be maintenance check-ins that are linked with their coming back to the clinic, right, to maximize the likelihood of people coming and the implementation as much as possible. And so this is back to the study design again, how we're planning to look at this with the conceptual model, hopefully set up it's set up to look at mediating mechanisms, and hopefully we'll have findings to do that. So I just want to conclude with this what I think is an interesting sort of series of comments that came out of the economists winning the Nobel Prize in their work in poverty, and that it's possible to do randomized controlled trial of things like poverty. And so I think I just want to pose this question, which is the thing I proposed in the beginning, which is, where are we in this field? What else do we need to do in mental health intervention trials? I don't really think we have enough evidence. What are the other questions we need to ask? Should we still be doing RCTs? You might have noticed, and this is what I think a lot of people propose now, is a hybrid effectiveness implementation model. So I think we try very hard as community-based collaborators to do studies that are going to be transferable to the community because they're done in that context, but not everyone does them that way. I think HIV has really advanced community research in that way. But sort of, do we need RCTs? Do we not? Are we ready for implementation science in some areas or not? And so I just think it's an important question for the field. And so let me just thank my various trauma teams over time. We've done this for 20 years. You have different trauma teams over time. So we'll bring it back up to the World AIDS Day slide and take questions. Yeah.
That was excellent.
Thanks.
I was totally riveted. So in the trial that you're going to be doing,
yeah.
Given that there are some people who don't ever initiate treatment, is it now powered to be able to look at just people who do?
Yeah. So they're gonna when they're gonna come into the study has changed, such that and it's helpful for us because we've decided they have to have initiated within the past 4 months. So we might screen them at the day they're told they're going to be on ART, but we basically have a 4-month window to be sure they start because of the power dilemma in being able to show the viral suppression, whether our sample is really, and comparing it to another treatment. And we have all these sort of things stacked against us in terms of sample size. But I mean, we've done the power calculation for that, but it's a big question. So we will not baseline anyone who's not already started. Yeah.
Thank you so much.
Yeah.
So, I drink the Kool-Aid now. So I think I'm like, for all intervention studies, we should be assessing for combo because that would be an explanatory factor for why intervention works or doesn't work.
Yeah.
And yet, I feel like one of the reasons people don't ask about trauma is because they fear that asking is traumatizing and that there's also an obligation of it because you're once
Right.
you uncover that, you have to do something, and a lot of studies feel unprepared to tackle on the studies. So I'm curious what you have to say about that.
Yeah, it's so. I mean, you've really hit the nail on the head, which is, I think that is a big reason people don't include. I mean, we include all kinds of other things just in case they're related, but it's actually complicated to ask, right? I mean, you know, I sometimes say, like, on my gynecologist sheet, it says, were you ever abused as a child? Yes or no? Does your partner hit you? Yes or no? And I actually put yes a couple times to see if anybody would even look at it, and of course they didn't. Right? Like, nobody ever followed up. Like, okay, great, it's on the screener. But I marked yes, and nobody ever said anything to me. It's my own little mini experiment. But I think, so there's this way of, like, can you ask in a way that gives you enough information? Like, that may give you enough information, but probably not enough to really understand if that's a mediating influence. So I do think for the data to be good, to be, like, help figure out if it's related to some causal mechanism or influencing, it's how much do you ask, and then what do you do based on what you ask. And I think that I think it depends how much you think it's important to know, right? And then, I mean, I think if we're set up to handle depression, why aren't we set up to handle referral for trauma? Like, why can't we just do it? Why are we so afraid to ask and figure it out? So I do think that's a part of it. I will say that after all this time, NIMH finally had an RFA on trauma that came out last April, you know, and that was because Terry Sen, the project director, has known the importance of this, and she and I have talked a lot about, like, why is it that there isn't more of this work, and what is the barrier? I will say I talked this over with Mary Jane Rotheram, because she works in a lot of these similar clinics in Cape Town, and it was interesting what she said, because I said, you know, why do you think people don't tell providers, or what might we need to do to get providers ready to handle this? And her response was interesting, and I've thought a lot about it, which is, in that culture, if somebody tells you that, you need to do something, right? Like, the collectivist aspect of it would mean, then I need to do something to protect you. I might need to get you to a shelter. And people just feel like they don't have the capacity. So I think there are all these, I mean, even from the clinical perspective, not just the research perspective. Yep. Yeah.
Thank you so much, Kathy.
Sure.
Kathy was, when I was on the study section, Kathy, she was my teacher of how to handle study section. I won't say anything.
Well, okay.
So there's a lot in here that
Yeah.
I would love to ask you about. But, you know, I think there's a few things that you said that I'm just trying to wrap my head around. The first is, it started out with telling an HIV, or sometimes reinventing wheels from other fields.
Yeah.
And that crossover need. And so I'm just,
Yeah.
so I was thinking a little bit about that, and are there things that we can learn, that you clearly are about trauma, but also like other things like the sexual assault literature, et cetera.
Sure.
Although I
Yeah.
learned that there is no NIMH group that actually does sexual assault research or focuses on it.
Yeah.
Mm-hmm. There's an incredible amount of revictimization.
Yeah.
And, you know, one of my team members is here, and we hear a lot about trauma.
Yeah. Yep. Sure.
And I think they're willing to tell us in a research study, any of those reasons that you're saying, there isn't an intervention that has to happen right after that.
Yeah.
But there is so much revictimization, and I love that you're dealing with avoidant coping and some of the things that might mediate that.
Yeah.
But
Okay.
do you have thoughts about some of what you're doing to start younger? And how you would handle that to prevent something?
Yeah, I actually, after LIFT, I thought a lot about, should my next study be, how do you prevent from first occurrence of abuse? And I did a lot of, like, looking into who would you partner with in communities, and how would you do that, and how would you find those young people or children or adolescents? And honestly, that's, I mean, talk about dealing with adults, dealing it with children was like, just wasn't a world that I was familiar, honestly, enough to feel like that was my expertise to go into. I mean, I came into sexual trauma through grief and, like clinical work. And I often say I'm not a PTSD person, I'm a trauma and HIV person, so you have to be careful, like how much expertise you say you have in a particular area. I think I've come to really understand PTSD, but I wasn't trained by FOA or, somebody that created things. So, I mean, I think it's incredibly important, but it's also a challenging research question, which is like, how do you measure prevention, right? I mean, who would you enroll in the studies? People that have children or adolescents, but there's like what I was saying about Audrey Pettifor's work, documenting that the physical violence from a partner looks like it's predictive of HIV infection later in trying to negotiate condom use. I mean, it's one of the first study to kind of look at that. And so where might you be able to capture adolescents or young people at risk in a way that you could intervene much sooner? Yeah.
Great talk, thanks. Can you talk a little bit about the role of substance use, like how that works from the standpoint of how intervention goes?
Yeah, that's a great question. So, how would I say this? It was in the U.S. studies, it was highly related. I mean, very related. I have to think about this now, but I want to say like 2/3 probably had substance abuse disorders. And in the bereavement study, this is another side comment, that review panel wanted me to exclude, this was the 90s, don't forget, they wanted me to exclude people with substance use disorders and personality disorders and everybody that I think of as our people. So what I did was I said, I will do a skid and I'll stratify, but I'm not going to exclude all of our people. And it turned out that if I would have excluded everybody, about 1/4 of them would have been eligible. So I mean, I think we just know that substance use is integrated into all of this. And I gave a talk similar to this in SMS, and Bob Fullilove handed me his papers from 1992 about PTSD and substance use. I'm like, I know, Bob. I know, this isn't new. We know this is the case. But we haven't really done interventions specifically to address it, which I just find fascinating. There's just not as much substance use, at least reported in these women. I'm not sure if that's a function of being concerned. I mean, it's as private as it can be, but they may feel in the HIV clinic they shouldn't be reporting TIC use or other, I mean, TIC is methamphetamine there. And, so there's alcohol, but not as much as I expected. We're going to obviously assess a little bit more extensively in the full trial, but I think it's highly related. It's okay. Yeah. Yeah.
And I'm wondering how, at least from a measurement standpoint, you consider other sectors, right? Because a big kind of
Consider other what? Sorry.
Sectors.
Sectors. Okay. Yeah.
The referral network that you talked
Yeah.
about.
Yeah.
Where in South Africa and Cape Town,
Yeah.
maybe successfully refer somebody.
Yeah.
And issues around policy, policing,
Yeah.
enforcement.
Yep.
Because, I mean, trauma could be a crime. depending on
Exactly.
what and how it
Exactly.
happens.
Yeah.
In many
Yeah.
cases, should be reported as something
Yeah.
that happened.
Yeah.
And that helps the person as well.
Sure.
So I think, so it's sort of a multi-sectoral.
Yeah, I think it's an excellent question. I mean, I wish I could say that we've done a lot of effort to try to find the right referral networks and we've basically been able to get some NGOs that provide support and certainly have literally taken women to shelters. Unfortunately, there's occasionally like a half-day psychologist, but in the clinic where we were, there was a half-day psychologist who was white and didn't speak Xhosa. So who are you going to help? Just, you can't, right? But I've learned these fascinating things about getting a master's in clinical psychology there is as competitive as here. Like the university takes 4 students a year because they don't have the resources, not because they don't have the need. So I think, there are these other much higher policy level questions about getting more mental health providers. Because UCT is a department, we work in the Department of Psychiatry, we do have a way that helps get people to the psychiatric hospital when they're clearly suicidal. But that's like our version of a state psychiatric hospital, right? And so, it seems like there's community services and then there's psych hospital and there's maybe half a day a week. And it's getting better. It's improving and I think it depends on clinic. But I will say it's one thing I do love about working with the colleagues that we have there on World Mental Health Day a few years ago. I went to the Parliament with them because they've had such an impact on mental health policy. And, that's invigorating to say these are people that do global mental health research, and they're working with the city to try to get services. And one of the critiques of ethics, that the UCT ethics was, now that it's policy in Cape Town that anyone who has depression should have access to antidepressants, they wanted to know what we were going to do. It just wasn't what I thought there, but at least now there's a policy that says you better figure this out, even though there aren't resources yet. But maybe that's a better way to go, like set a policy and then get resources in place. So I think, I couldn't agree with you more about the importance. I wish I could say that we've sort of mastered how to do all that. Well, thank you, everybody. It's nice to be here.